Welcome back to Caridac. In this lecture, we will discuss CAD, which is coronary artery disease, and some medications used to treat this cardiovascular disorder. Before we discuss coronary artery disease further, I just want to make sure it is clear what this means. It really means there is disease inside the coronary arteries. And remember, those coronary arteries branch off the aorta, seen in this picture, and they get smaller and smaller and smaller and smaller down to the capillary level to feed the muscle of the heart. Several conditions result from coronary artery disease, such as angina, MI, which is myocardial infarction, or better known as heart attack, heart failure, and also sudden cardiac death. In Block 2, we will be discussing here coronary artery disease, and in a future lecture, we will talk about chronic stable angina. When you move into Block 4, you will start to discuss acute coronary syndrome and then different types of myocardial infarctions that result from ACS. Coronary artery disease is the leading cause of death and illness in Western societies. This diagram, although old data, really highlights that fact that the majority of deaths in the United States in women and men are from coronary artery disease or cardiovascular disease. So what is coronary artery disease? It is a type of blood vessel disorder included in that general category of atherosclerosis. And as you know, atherosclerosis is characterized by focal deposits of cholesterol and lipids within the intimal wall of the artery. Inflammation and endothelial injury play a central role in the development of atherosclerosis. Coronary artery disease is progressive and it develops in stages. And when it becomes symptomatic, the disease process is usually well advanced. Just some other statistics. 500,000 women die each year from cardiovascular disease. Just compare that to 40,000 that die from breast cancer. Cardiovascular disease is the #1 cause of death and major disability for men and women in the U.S. And coronary or cardiovascular disease is the #1 most common admitting diagnosis on admission to nursing homes. So this is such an important topic to understand the nurse's role with these patients, because you will take care of patients with cardiovascular disease and more specifically coronary artery disease. From the preparation, you understand what coronary artery disease is. So what are some nursing diagnoses that go along with coronary artery disease and also angina, which is a symptom of the coronary artery disease? Well, the first nursing diagnosis I think that is important for us as nurses is ineffective therapeutic regimen management, because that is related to a lack of knowledge of risk factors, disease process, rehabilitation, home activities, and medications. So we as nurses have a unique role where we can give good education to these patients to help prevent this disease from progressing to the symptomatic phase, or if it's already symptomatic, really educate those patients on how to prevent further coronary artery disease from developing or a progression of that coronary artery disease, which could lead to heart attack. Some other nursing diagnoses that would be appropriate are ineffective tissue perfusion related to myocardial injury, acute pain related to myocardial ischemia, anxiety is when someone is actually having that chest pain that is related to the coronary artery disease. They feel that perceived or actual threat of death, pain, or possible lifestyle changes because of what's developed. And also, they could develop activity intolerance. And that could be related to the fatigue secondary to decreased cardiac output and poor lung and tissue perfusion because of that atherosclerosis. In the last slide, I said that we as nurses have a unique ability to teach these patients how to prevent the coronary artery disease from even developing or how to prevent it from progressing. And how do we do that? Well, I have a hyperlink here on this slide you can go to. It takes you to the American Heart Association and takes you to their page about coronary artery disease, and they have something called Life's Simple 7. So these are the 7 things they would like patients to do to help prevent coronary artery disease or slow its progression. And these should look very familiar to you. Like I said, you can go to that webpage, but I'll just read you their Life Simple 7. They would like patients to manage their blood pressure, control their cholesterol, reduce their blood sugar, get active, eat better, lose weight, and stop smoking. A lot of these should sound very familiar from your lifestyle modifications for hypertension. Because remember, hypertension can lead to coronary artery disease. When blood pressure is too high, it stresses those arteries throughout the body. Here we're talking about the arteries in the coronary arteries specific to the heart. But when those arteries are stressed, they are damaged, they have inflammation, and they are more likely to develop atherosclerosis, which leads to coronary artery disease. So all of these lifestyle modifications that you learned about for your high blood pressure are the same here to prevent coronary artery disease. It's kind of on a continuum. Talking about hypertension, which could lead to coronary artery disease, which can lead to angina, which we'll talk about more in a future lecture. So trying to do preventative work to prevent the progression of hypertension to coronary artery disease and angina, and then even worse in Block 4 you'll learn about, which is heart attack. Another preventative measure is for us to educate patients with coronary artery disease to make sure they are up to date on their flu and pneumonia vaccines and any other vaccines that may be relevant. What has been found is that when someone gets one of these upper respiratory infections, it causes a systemic inflammatory process. Well, again, that can inflame the coronary arteries and lead to, obviously they have coronary artery disease already, and it could lead to more symptoms like angina or even worse. And what has been found, they've done some research, and this is interesting. If you are diagnosed with flu or another respiratory tract infection like pneumonia, the odds of having a heart attack are 5 times higher during the 3 days after diagnosis than it would be otherwise. And it has been found through research that the flu vaccine can cut heart attack risk by 20%. So yes, vaccines are part of preventative maintenance in patients with coronary artery disease. Now, if a patient already has coronary artery disease or is at great risk for developing it, medications will be necessary. Let's look again at that coronary artery that is diseased. You can see the atheroma plaque, and you can see the platelet plug that forms over that. So if this is what your patient's coronary artery looks like, I think it makes sense that they would need blood pressure medication. One, we want blood pressure controlled so it's not damaging that internal lining of the artery, which leads to buildup of plaque. And also, when we've got a diseased artery, look at that lumen. that's where the oxygenated blood flows. And so we'd want that nice and open, and blood pressure meds help achieve that. The other and we've talked about those blood pressure medications. So just know that all those blood pressure medications we talked about would also be applicable to your patients with coronary artery disease and or angina. Also for these patients, which we're going to talk about in this lecture, are cholesterol lowering drugs. We want the patient to have less ability to build up these plaques. And we also want the patients to not build up platelet plugs, which also decrease the lumen of that artery. So we will also discuss antiplatelet medications. First, let's jump into a discussion about lipid-lowering agents, also referred to as anti-hyperlipidemic agents. So you may see it referred to in different ways in different resources. Before we have a discussion about the medications that reduce cholesterol, let's have a quick discussion about metabolism of fats in the body. Let's say we eat a cheeseburger and french fries. Maybe it's not your favorite, but it's one of my top meals. I love it. It goes into the stomach, and the dietary cholesterol and saturated fat are processed in the GI tract. They're processed into these chylomicrons, and then they enter the bloodstream. They are broken down into these chylomicron remnants in the capillaries, and then the liver processes them into what are called lipoproteins. When these are released into circulation, excess low-density lipoproteins, or LDLs, adhere to receptors on the intimal wall, so inside the arteries. And that would be all arteries throughout the body. Of course, here we're talking about the coronary arteries, but they are not, they don't discriminate. They would like any artery. Macrophages also ingest those LDLs and transport them into the vessel wall, and you can see that here in the picture, beginning the process of plaque formation. But look at the liver. It does produce different types of lipoproteins. As I said, the liver does produce different types of lipoproteins. This slide does have a great hyperlink that takes you to a video that describes those, and it can also be found in your Canvas video module page. But let's discuss a couple of the different types. The LDL, low density lipoproteins. These are the bad ones. These are the most atherogenic, so they put fat into the artery walls. So these you want very low when we look at someone's cholesterol profile lab results. The HDLs, or high density lipoproteins, those are your good guys. They actually go around and pick up some bad stuff and get it out of circulation. And so you want those high when you're looking at a patient's lipid profile. These increase with exercise. So here is a cute slide that just helps you remember those. The LDLs you want low. If not, the client will feel lousy. And your HDLs you want high for the client to feel healthy. Although high serum cholesterol, that total number, is associated with cardiovascular disease, it is not adequate to simply measure that total cholesterol in the blood because there are different types of cholesterol as we just discussed. So let's talk about some numbers that you need to start memorizing. When we look at someone's total cholesterol, we would like that number to be less than 200. And this is all in milligrams per deciliter. So we want that total cholesterol to be less than 200. But as you smart nurses know, it's not just about that total cholesterol. We need to look at the different subtypes. So where do we want the low density lipoprotein? Well, that's the bad one. So we want that number very low. So we would like that to be less than 100. How about the high density lipoproteins? Well, remember, that's the one we want to be high. And so we would like that to be greater than or equal to 60. And triglycerides are part of those very low density lipoproteins. So they are also bad. And we would like those to be less than 150. So start to memorize, commit those to memory, the total cholesterol, LDL, HDL, and triglyceride levels that we would like to see in our patients. This is an FYI slide, but I just wanted you to be aware that there is an estimated 31.9 million American adults that have a total cholesterol level greater than or equal to 240. And remember, we want that to be below 200. So there are guidelines on when adults should start being tested with a fasting lipid profile. And fasting lipid profile is considered the most accurate evaluation of lipids. So if you've ever had this done, they'll either tell you to fast, or when you come to get your blood tested, they'll ask you if you were fasting, because that makes it the most accurate. So you can see the difference between males and females. It's more just with age. So yes, they do suggest we start getting tested every 5 years at the age of 20. Now, of course, if somebody has more risk factors, they are probably going to be tested more often. And some of us are just what I call genetically screwed. Some of us just have high cholesterol, and it's more of a genetic component and not so much about lifestyle. And so even if a patient may be 25 years old, but with really strong family history and really high cholesterol, they're not going to wait to check them every 5 years. They're going to do it every year, if not more frequently. So these are just some general guidelines so that you are aware what those guidelines are. What can lead to hyperlipidemia? Well, it could be caused by an excess of dietary intake of fats. We saw in that metabolism of fats slide that if we eat a meal high in fats, like our cheeseburger and french fries, unfortunately, the body's going to break that down and use it and actually store cholesterol, because the body actually needs cholesterol. It needs fat. All of your sex hormones are made of cholesterol. And if you do not eat enough cholesterol, the body will produce its own. Every cell in the body has the ability to produce cholesterol. And it does that using this enzyme, HMG-CoA reductase. Okay, and so every cell can actually produce its own cholesterol. But one way to cause it is if you eat too much fat. But the other reason is just genetic. There are certain people, like I said, I call them genetically screwed. They have a predisposition for their body to produce excess cholesterol even when they don't need it. And I have known people that are very healthy in terms of their lifestyle. Their BMIs are where they should be. They exercise. They don't smoke. They don't drink excessively. They're eating healthy. And their cholesterol levels are in the 3 and 4 and 500s plus. So there are people that no matter what they eat and what their body needs, their body's cells are just producing too much cholesterol. So there are medications that can be used to lower cholesterol, and lipid-lowering agents are used as an adjunct to diet therapy. And just so you're aware, all reasonable non-drug means of controlling blood cholesterol levels, like diet and exercise, may be tried or suggested or we educate the patients about for up to 6 months and found to fail before drug therapy is considered. Now again, that may be somebody where their blood cholesterol is around that 240, and there are some lifestyle modifications that can be made, and then they'll retest them. If you have patients that come in and they're in that 3, 4, 5 plus 100 cholesterol levels, they're not going to wait the 6 months to start them on medication. But I just want you to be aware that lifestyle modifications are important for these patients, even if they are started on the medications. What medication will be used for these patients? Well, it depends on what their lipid profile looks like, because certain drugs work better at reducing LDL or raising HDL or decreasing triglycerides. So it will depend on the patient, and that is decided upon by the healthcare prescriber. Here is a great slide that shows those lifestyle modifications and also medications that can raise or lower HDL and raise and lower LDL. So remember, HDL, we want that high. So we want to promote things in our patients that raise that HDL. There you can see the exercise, weight loss, smoking cessation. Estrogen is very protective, and that's why as women age and lose estrogen, they develop more cardiovascular disease. You can see what lowers the HDL, kind of the opposite of a lot of what is on the other side. And the LDL is your bad cholesterol, so we want to lower that. Again, those should look very familiar in terms of the lifestyle modifications to lower the LDL. But what you can see, there is one drug that I want you to keep in mind, because not only does it raise HDL, it lowers LDL, and those are your statins. And we're going to be talking about those coming up here in just a few slides. If a patient is put on a lipid-lowering agent, what do we want that drug to do? We want it to lower the serum levels of cholesterol and certain lipids, and hopefully then it will prevent cardiovascular disease, which includes coronary artery disease and peripheral vascular disease. Because remember, it's not like this cholesterol, it has an affinity just to the coronary arteries. All the body's arteries can be affected. So we hope to prevent that progression of cardiovascular disease and increase patient survival. There are 3 drug categories you need to know from this lecture for the treatment of hyperlipidemia, and those will be the HMG-CoA inhibitors, the bile acid sequestrants, and the cholesterol absorption inhibitors. There are lots of medications to treat high cholesterol, and we'll also just touch on a couple FYI meds, which are the fibrates and niacin. Hey, this looks a little bit familiar. Do you remember HMG-CoA enzyme? Okay, that is that enzyme within the cells, every cell in the body that can produce cholesterol. So it makes sense that patients will be given a drug that inhibits that enzyme. Our prototype HMG-CoA reductase inhibitor, better known as statins, is a torvastatin. You may also know it as Lipitor. This is, I believe, still the most widely prescribed drug in the United States. So knowing that tells you that cardiovascular disease is a big deal. How do statins work? All these drugs will end in the word part statin. How do these work? Well, they inhibit that enzyme, HMG-CoA reductase. They inhibit it from producing cellular cholesterol. I always tell students this. This does not prevent the patient from putting a cheeseburger in their mouth, but it does prevent the body from making excess cholesterol. And that's why lifestyle modification education is still extremely important with these patients. We know how these drugs work now. They prevent the body's own cells from making cholesterol. And so what do we hope happens because of that? We hope that there are decreased cholesterol levels. So there's a decrease in LDL, VLDL, and triglycerides. And then this drug is also awesome because it increases HDLs. That's the good cholesterol. And therefore, we have a reduction in the risk of myocardial infarction or heart attack and CVA, which is stroke. There are a couple contraindications with these types of medications, which are called statins. That is active liver disease, because these are processed in the liver, and also pregnancy. They are category X, which means studies have shown that this medication can cause fetal abnormalities. With atorvastatin, there are side and adverse effects to watch for. There could be a headache. Patients could have GI disturbances, so we say give with food. A big thing to watch for is hepatotoxicity. So as a nurse, you will monitor the liver function blood tests, which are ALT and AST. These are both enzymes that are found in high amounts in the liver. So when the liver is damaged, which could happen with this medication, these will spill into the bloodstream and we'll see the levels rise. So if you notice that happening, this drug needs to be looked at as a culprit and de-seed from that patient so that we don't cause any further liver damage. This drug can also cause muscle breakdown. And when that happens rapidly, it's called rhabdomyolysis. Maybe you've heard of it. A lot of healthcare professionals will just call it rhabdo. So what can happen is the muscle actually starts breaking down so quickly, and those parts of the muscle fibers, they are actually spilled into the bloodstream, and they go and they get caught in the glomerulus in the kidneys and can put a patient into renal failure. So nurses, you will watch closely for patients who complain about muscle pain, myalgia, with this medication, and you will also monitor what their urine looks like. This is a urine sample that is showing muscle tissue in it, rhabdomyolysis. Again, it can go get caught up in the glomerulus. As the glomerulus gets damaged, that muscle tissue gets through and into the urine. And I have had patients in rhabdomyolysis. Their urine looks much worse than this. You would notice it quickly. I've had patients in rhabdo with a Foley catheter or even without a Foley catheter, but when it's in that Foley catheter collection bag, you will see it'll be a dark red. It looks like a dark red wine, especially initially when it's happening. And I think any nurse would look at that and know, wow, that's something really important that I need to intervene with and notify a healthcare provider. So you're going to monitor for the patient to complain about muscle pain and also watching their urine. And you have to tell the patient this because most patients will be at home taking this medication. Just know that rhabdo, per the research, is pretty low. It's 5 to 20% of the patients, but still something to educate the patient about and for you as a nurse to watch for. Well, here's that grapefruit again. One of the big interactions with your statins, like atorvastatin, is grapefruit juice. Or grapefruit. So just say no to grapefruits and grapefruit juice. We've talked about that before. Taking a statin and taking grapefruit juice or grapefruit increases the risk of rhabdo. And that's because grapefruit actually interacts. It does different things within the liver, but it doesn't allow the liver to process the statin drugs well, so that can lead to liver problems and, of course, rhabdomyolysis. So just say no. Knowing how this drug works and all of the side effects, a lot of these nursing interventions should make sense. We need to make sure that patients do not take this medication when they're pregnant. And just think about it. Can women of childbearing age have high cholesterol? They sure can. And so this is a medication we'd need to screen them for, and they need to be off of it if they are pregnant. We want to, as nurses, watch their lipid panel. So all of those numbers we need to know. Total cholesterol below 200. We want HDL high above 60. We'd be watching those lipid panels for those changes when they're on these medications. Monitor their liver function tests, that AST and ALT, which could indicate, if they rise, that the patient is having hepatotoxicity. We're going to watch their urine and watch for muscle tenderness and educate those patients to watch for that at home also. Monitor for GI upset, and if they have it, they should take it with food. And they should also take this drug at night. Why? When is the liver most active? Which means when is it going to be producing the most cholesterol? Well, it's part of our rest and digest system. So it's most active at night. So you will see on your MARs at the hospital, and what you should educate the patient about is they should take this with their evening meal. Decreases that GI upset, they're taking it with food, and they're also taking it at night during that rest and digest period. Don't forget, even your patients on these drugs need to continue all those lifestyle modifications. They cannot have grapefruits or grapefruit juice, and they need to report muscle tenderness and weakness immediately to their healthcare provider. This is the summary slide from your pharmacology book about atorvastatin. And this is just a slide with some of the other statins that are out there, and I've heard some people call them the statin sisters. Lovastatin, pravastatin, simvastatin, on and on and on. So just know that if you see statin, they are a lipid-lowering medication that works by not allowing that enzyme to make cholesterol within the body. Very common medication, and you will administer it in your career. The next type of lipid-lowering medication that you need to know are bile acid sequestrants. The prototype you need to know is cholestyramine. Just so you're aware, bile acids contain high levels of cholesterol. Again, our body needs cholesterol for certain functions, and it is high in our bile, which, remember, helps with digestion. Bile acid sequestrants bind with the bile acids in the intestine. So it kind of grabs onto them, and then the patient will excrete that excess bile, hence cholesterol, in their feces. This is now considered an adjunctive treatment. This used to be a first-line treatment before those statins were introduced. And now they may be used in combination with statins, because not only are you reducing the body's ability to make cholesterol, these drugs will be used in combination to help rid the body through fecal matter of excess cholesterol. So cholestyramine, it is a powder, and it's mixed with liquid, and it may be prescribed up to 6 times a day. And that's why it's also not as convenient for patients. I don't know if any of you have ever had to take a medication that's prescribed more than once a day, but I bet you've forgotten to take some of those doses. So with this one being up to 6 times a day, it can be difficult. It does decrease total cholesterol and LDL. Here is your cholestyramine summary from your pharmacology book. Now let's discuss cholesterol absorption inhibitors. Ezetimibe is your prototype cholesterol absorption inhibitor. And it works by inhibiting absorption of cholesterol in the small intestine. So there is a decrease in total cholesterol, and it has been shown to block the absorption of up to 50% of the cholesterol in the jejunum. This also not a first-line treatment. It's used in combination with statins. Again, here is your summary from your pharmacology book about this medication. And as you can see, right under indications, it says even this medication is an adjunct to diet and exercise to lower serum cholesterol levels, and it's in combination with a statin medication. So yes, you may see patients on a combination or multiple medications to bring down their cholesterol levels. The next couple slides explore just some other lipid-lowering agents that you may see patients on. I will not test you on these. They are just FYI for now. Gemfibrozil is your prototype fibrate. How do these work? They stimulate breakdown and removal of lipoproteins. They decrease triglycerides. Also, they are actually the drug of choice for very high triglycerides. So if a patient's lipid panel shows very high triglycerides, they're probably going to be on this medication. And they also decrease LDL production and increase HDLs. So great drug, right? Sounds great. So why isn't it used widely now? Well, statins came along. And also these drugs have a lot of drug interactions. You can see if you put together gemfibrozil and statins, there's a much higher myopathy or muscle breakdown risk. So the recommendation is not to administer these together. If you combine gemfibrozil and warfarin, it's a higher bleeding risk. If you combine gemfibrozil and the anti-diabetic medications, there's much more risk for hypoglycemia. So because of these drug interactions, it's not as widely used today. Niacin is an over-the-counter lipid-lowering medication. It is actually vitamin B3. And niacin inhibits the release of free fatty acids from adipose tissue. It actually increases the rate at which triglycerides are removed from the plasma. It also decreases LDL, triglycerides, and increases HDL. Again, sounds like a great drug, but it does come with side effects. The big one is cutaneous flushing that people feel. And just so you know, yes, this is over the counter, but an over the counter dose for somebody who is just taking them as part of their daily vitamin regimen would be about 25 milligrams a day. To reach high enough levels in the body to get these lipid lowering effects, the patient would need to take 2 to 3 grams per day. And that's why the side effects are so much more pronounced when someone is taking it for that reason, because they're taking such high amounts. And we would not encourage them to do this over the counter. This should be prescribed and monitored by a healthcare provider. They could also complain of nausea and abdominal pain and an increase in their uric acid. This is just a great diagram that shows how each of these medications we've discussed that decrease lipids and cholesterol, where they work in the body. So please use this as a study guide. The last type of medication we will discuss in this lecture are antiplatelet agents. Why are these good for somebody with CAD? Well, don't forget this picture. They may have what's called that platelet plug that's surrounding that atheroma or atherosclerotic plaque. And this platelet plug, if it continues to grow and develop, it's going to make this lumen of the vessel smaller and smaller and smaller, Less blood flow means less oxygen to the heart muscle, and that'll lead to angina and even worse, a heart attack. So antiplatelets are a big piece of the treatment for patients with CAD. This diagram depicts in words what is shown on the next slide with pictures, that when there's a vessel injury, the body is going to try to stop that injury, that hole where the bleeding is taking place, plug that hole up quickly to prevent the loss of blood out of the vasculature. And it does that very quickly by the activation of platelets. And they form a little platelet plug. And then the fibrin comes in and solidifies that clot. So we need clots to form, or else we wouldn't live very long. Every time we got a cut, we'd never stop bleeding. So we need these clots to form. Unfortunately, in patients with coronary artery disease, if they keep forming in an area of an atherosclerotic plaque, like I said, that lumen of the vessel will get smaller and smaller, leading to less oxygenated blood flow to that tissue, and in this case, it would be the cardiac tissue. So we need to have a medication that actually decreases the ability of platelets to form a platelet plug. The antiplatelet prototype you need to know, and I'm sure you've heard this medication mentioned before, is aspirin. How does it work? Well, it works in two ways. It not only prevents the platelets from forming a clot, but it also prevents the fibrinogen from binding to those platelet receptors. Again, when there is injury, even if there's not a hole in that vessel wall, those platelets will come and sit there first, and then the fibrin will come and help stabilize that clot. This kind of depicts really high blood pressure, really high blood sugars that are damaging that vessel wall. And when we talk about coronary artery disease, it's those coronary arteries supplying the heart muscle with blood and oxygen. And so when that damage takes place, maybe from smoking, high blood pressure, high cholesterol, then the platelets will come and try to patch up that little area. Remember, the cholesterol goes there too, forms an atheroma, and then the platelets come and try to plug up that damaged area. So this medication, aspirin, prevents the platelets from doing that well. So the antiplatelet aspirin is mainly used for prophylaxis. It's used to prevent heart attack or PAD or CVA. Again, if we can recognize someone has coronary artery disease, they'll be on an aspirin regimen to help prevent that from progressing into a heart attack, peripheral arterial disease, or a stroke, which means we've actually cut off blood flow altogether to these peripheral areas. It also is used to help prevent a repeat of one of these events. And aspirin works to prevent arterial clot formation, because when we talk about venous clot formation, you will learn that patients are put on medications like warfarin and heparin to prevent the venous clot formation. So aspirin, arterial. Here is your summary from your pharmacology book on aspirin. And of course you can see that it is used for other reasons. It's used as an anti-inflammatory and analgesic and to reduce fevers. But I will tell you, if someone is on an aspirin regimen daily for coronary artery disease, it's once a day. Maybe they take one baby aspirin a day or one 325 milligram aspirin a day. If you see a patient on 81 milligrams once a day of aspirin, they're not taking it as an analgesic. I don't know about you, but if you've ever been in pain, I bet the last thing you said is, oh, I'm going to have one baby aspirin today for my pain. No. patients on 81 milligrams, they're using that prophylactically to prevent these clot buildup in the arteries. Now, if they take aspirin more frequently, it may be used for another reason, and that's why as nurses, smart nurses, we're always figuring out why my patient is on a medication. There are other medications that are antiplatelet medications, and one you definitely need to know is clopidogrel. Now maybe you know it as Plavix, but it is definitely a commonly used antiplatelet medication. It's used in acute coronary syndrome, which is what you'll learn about in Block 4. But it's also used for patients with just histories of coronary artery disease, peripheral artery disease, stroke, heart attack. So it is another antiplatelet to be knowledgeable about in terms of its name and how it works. This is just a great diagram to help with your studying of clopidogrel, also known as Plavix, but you're going to know clopidogrel, which again is another frequently used antiplatelet medication. So now that you know how an antiplatelet works, let's talk about what we need to know as smart nurses when we have a patient receiving one of these antiplatelets. The big thing I have at the top is observe for signs of bleeding. And so you may think to yourself, oh, okay, if I see my patient bleeding. Well, the bleeding you can see is the bleeding as a nurse I like. Because if I can see where you're bleeding from, I know where to put pressure. You know, if you're bleeding from a puncture wound in your arm or leg, I know where to put pressure. If you're bleeding from your gums, I know it's an oral health issue and I need to, I can see it and I can intervene. It's the bleeding I can't see that I always need to be extra observant for. What do I mean? Well, the bleeding I can't see internally. I can't see the red blood. So how will I know my patient's bleeding internally? Well, I've got to watch vital signs, because if someone's bleeding internally, their blood pressure is going to go down, and as a compensatory mechanism, their heart rate will go up. What about if they're bleeding in their brain? What am I going to watch for, smart nurses? Well, I'm going to watch for a change in their level of consciousness. So it's the bleeding I can't see that I definitely need to be a better, astute nurse and watch for those signs and symptoms. And we need to educate the patients about that too. Of course, if they see dark, tarry stools, again, I can see that. The patient can see that. That's a problem. If they get petechiae or a bunch of ecchymotic areas on their body, that's something they can see and they need to report. But don't forget about those more discrete signs of bleeding that we can't see. What are we going to teach our patients about when they're on antiplatelets? We don't want them mixing it with alcohol or other anticoagulants without talking to their healthcare provider. All doctors need to know that patients are on this. Any surgeon, any dental work, they need to know because they are more likely to bleed. They can't clot as quickly. It does need to be DC'd 1 week before surgery if possible. They should take these medications with food and fluids because it definitely can cause irritation to the GI mucosa, and they need to notify someone immediately if they are having GI distress or those black tarry stools or having hematemesis where they're vomiting blood. And then they need to report any of these side effects, the bleeding, the tinnitus, headaches, dizziness, GI symptoms, visual changes, and or seizures. So that is the end of this recording. I look forward to discussing more cardiac content with you in your next audio lecture. Take care.